let me introduce Dr. Calico. He's a child and adolescent psychiatrist in private practice. He is a clinical assistant professor of psychiatry and behavioral sciences at New York Medical College and also teaches at New York Presbyterian Columbia University Medical Center. He is the author of Kids on Meds and Your Child in the Balance, Solving the Psychiatric Medicine Dilemma. So let's welcome Dr. Calico.
Thank you very much. Give me 1 minute to get reestablished here. Is that okay? Good, okay. So first of all, thank you all for coming out here at 7 o'clock in the morning. I see that some of you have your cup of joe in hand, and for those, I think we'll be joined in a few minutes by some others who took a behavioral route to waking up, the Zumba class next door. I'm sure that they're both equally good, and if we learn anything from psychiatric research in children, it's that the pharmacological and if you take the behavioral together work better than either alone. So next year I expect to see all you guys with a cup of coffee in hand at Zumba first, then the cup of coffee, it works better. Okay. So let's first, so disclosures. My only disclosures are the two books. You know, one a book to help parents decide about medicine and the other about the medicines. What we're going to do is talk mostly, I learned from last year that you all are mostly interested in ADHD and depression anxiety. So I kind of weighted it that way this year. But we have a lot to do, so I'm going to kind of keep going. A few months ago, I was in a cab, and I happened to be sharing it with a young nurse, I think from Ireland, from the airport, and we got to talking, and she found out I was a child psychiatrist, and she said to me, "So do you believe in psychiatric medicine?" And it was very interesting. I mean, you know, she's a professional, and she made it into an article of faith. You know, you can believe in God or not believe in God. Psychiatric medicine is medicine, and it's there, and it's useful, and it's tested. It's not a belief. But the reason I'm bringing up the story is because one of the things that I want to do this morning is not only give you the information that you need about these medicines, but to also give you some, I want to highlight some points that you all have to, I think, stress to the parents that you talk to. Because as far as I'm concerned, you are clearly the front line of pediatrics, and you probably talk to far more parents than I do in the course of a day. And getting some of these points across is going to be really very, very important. So I'll try to highlight some of those. A little bit of background. I'm a clinician by trade, you know, not an academician. So, you know, in terms of the latest research, I'm probably not the guy to talk to. It's more about what works in the field. Also, for the purposes of our talk, I'm going to use generic names, and sometimes I might slip into brand names, not because I'm being paid by any drug company, but because I want you to know what I'm talking about. And if I use only generic names, sometimes I think you'll get lost because we all use the brand names. Although these days there's a whole lot more generic going on. Also, I'm going to assume, we're jumping right into medicine, okay? I'm assuming that the child has had a good evaluation and that the diagnosis is correct. So there's a whole lecture that could precede this lecture that we're not going to do. I'll make a couple of comments about various disorders, but really we're jumping into kind of the pool of pharmacology. Okay, now, because we have a real limited amount of time, I kind of set this up this way. You can see I allowed myself a certain number of minutes. I'm going to really try to keep it that. And if I get off base, you can like just kick the horse a little bit, and I'll go faster. First, though, we're going to start with thinking psychopharmacologically. We have to spend a few minutes about that because it's not simply about learning about the medicines. The truth is that for a lot of you who are going to be in this field a whole lot longer than I will be in the future, the medicines are going to change. Okay, they have changed from 20 years ago, and they're going to certainly change 20 years from now. It's going to be the principles that really stay with you over the course of time, even though a lot of the names are going to change. So I want to focus on that. These are the basic, this is kind of an outline, a handy-dandy guide to what we're going to be talking about. But the first thing that I want to point out, and it kind of gets to our next slide, is that there's no system here for names, okay? So if you look back at what I called the antidepressants, okay, well, one of the things that you're going to see is that the antidepressants are far better anti-anxiety medicines than they are antidepressants, but they're not really called anxiety medicines. So don't trust the names. The antipsychotics are used far more often in children who do not have psychosis than those with psychosis. Okay, again, don't trust the names. Mood stabilizers. I mean, I would say that maybe once every month or two, I get a call from a parent for an evaluation, and it typically goes like this. Hi, Dr. Calico, I think my daughter needs to be on mood stabilizers. And my 15-year-old daughter needs to be on mood stabilizers. I said, well, what makes you say that? And the answer is always, well, her moods are very unstable. Now, that makes perfect sense to the parent because they're looking at those words that label mood stabilizer. What I have to explain is that mood stabilizers is just kind of psycho talk for the medicines that we use in bipolar disorder. Then everything changes. So the point is, don't trust names, and when you're talking to parents, you have to explain to parents not to trust names. Otherwise, you're going to say to a parent that I think that your child needs to be on, let's say, fluoxetine, okay, Prozac, for anxiety, and they're going to look at you and they will say, as they have many times to me, you didn't say anything about depression. Well, you didn't, because there's a mix-up in the names. Okay, now, this is your brain, just very simplified. It's also my first graphic that I ever did on my own without one of my children, so I'm proud of it. And we're going to focus, as you can see, on the synapses. Now, what we know about synapses and the way we all kind of think about the medicines that we use in psychiatry are that the medicines increase and decrease the different neurotransmitters, so that the stimulants, increase dopamine and norepinephrine in the synapse and so forth. And there's definitely truth to that. This is I think, a valid slide. However, the point is, don't get comfortable. Now, you don't have to read this, really, but this is what aripiprazole, Abilify, does. And you can see that it is far more complicated than just simply changing, than dopamine blocking. That's highly simplistic. The brain is, as you know, a very complicated place. These medicines go all over the place, and I always, tell people that medicines are kind of like adolescents. They go wherever they want, okay? They go all over the body looking for places to affect. Sometimes they affect, different organs, and we have side effects, and sometimes they affect different parts of the brain that we want them to affect. And sometimes they even affect different neurotransmitters. So don't get comfortable is really the point. Now, so when we're talking about medicines and the treatment decision, the question is always going to be, and you all know this from your training, as doctors and nurses have for thousands of years. I'm not sure there were nurses thousands of years ago, but certainly going back to Hippocrates, you weigh the risks, you weigh the benefits. Very simple. This slide is actually probably the most important slide of the morning. And the reason is because it expands that notion of weighing risks and benefits. What it says is that, yes, you should weigh the risks and benefits of medicine, but you should also weigh them against the risk. We're going to do nothing. Well, that's fine, and sometimes that's a very reasonable decision. But what they need to know is that doing nothing is doing something. And the more that we know about psychiatric diagnoses and disorders in children, the more we have long-term studies, the more we know that a lot of these disorders don't necessarily go away, or certainly not for everyone. They might for some people, but for a lot of people, the disorders stay, and they can be fairly malignant. In fact, they can be very malignant. And so how do you measure the benefits? Again, you know, there's case studies, everything from case studies to double-blind placebo-controlled studies, and we're going to kind of lean today on double-blind controlled studies because that's really what tells us what we know as opposed to what we think. I mean, as you know, anecdotes are a dime a dozen. We all have them and we're all impressed by them because that's the way our brain thinks. You know, when we hear a life story in Time magazine, it rings with us and we say, wow. But the truth is that that's just an anecdote and we need controlled studies. You know, when you take those anecdotes and you put them to the test, you often find that they actually don't work. And you know, the history of all of medicine is kind of littered with ideas that when put to the test of a double-blind placebo-controlled study, it simply didn't work. And we'll see some examples of that this morning. I would want you to remember the tricyclics and depression. Now, you know, you probably have to be older than, I don't know, maybe 55 or so to remember the tricyclic antidepressants. They're still around. I'll have one slide. But they were the go-to medicines for depression in adults certainly during the 60s, 70s, and 80s before the SSRIs came in the late 80s. Back in the 70s and 80s, as there was more of an understanding that children became depressed, you know, people said, well, how do we treat it? And they said, well, we should use the tricyclic antidepressants because they clearly work for adults and they're proven to work for adults. And so that's what we used back then. Unfortunately, when it put to the test, it was shown that the tricyclic antidepressants don't work the same for children, and they're not effective antidepressants as a rule for children. So we were getting a lot of risk for very little benefit. Also, I want to make a point here about the drug du jour. Okay, we all know that, and I won't name names because it'll seem unfair of me, but anybody who's been around for a few years knows that every so often a medicine comes along and it's like, wow, this is it, okay? It's never it, okay? You know, I remember learning about this in medical school, you know, 35, 40 years ago, and it's, you know, and now I see that it's really true. You know, medicines, you know, they're hot for a while and then they move on. So don't get caught up in the drug du jour. Look for that double-blind placebo-controlled studies. Having looked for that, now you're on a little bit of a slipperier slope. Namely, it's not just one study that you want. You want to know, has it been replicated? Because oftentimes they're not. You want to know, do the patients in that study look like your patients? And I will tell you that generally the answer is no. The reason is because a lot of times the studies kind of, in a sense, cherry pick, you know, the patients who fit their diagnostic criteria, okay? But what you know is that in your clinic, patients haven't read DSM-5. They don't come in with simple this or simple that. There are lots and lots of comorbidities, and that always makes things more complicated. Okay, so let's move on. How do you look at the risks of medicine? How do you measure the risks of medicine? We could talk all morning about that. We don't have time, so I'm reducing this to my one rule that I teach parents, and this is another rule to teach parents, and that is, whoops, oh, nuts. I apologize. This is on my computer, but we didn't have it set up for the computer, so I'm on a thumb drive in the back, and there's a photo here that is deleted, so I apologize. The answer to the question is, how do you reduce side effects? You reduce it to 3 letters, as far as I'm concerned. The 3 letters that keep me awake at night. L-I-V. That's not Liv as in Liv Ullmann, the actress. That's lethal, irreversible, and very painful. If a side effect has one of those types, if a medicine has one of those types of side effects, then I'm staying awake at night saying, is the benefit of this medicine really worth the risk? Now, sometimes the answer is yes. Sometimes the patient is in such dire need that the answer is yes, but not always. And so anything less than lethal, irreversible, and very painful, as far as I'm concerned, is kind of the cost of doing business. If when a mother calls me and says, well, I don't want my child to be on Ritalin because it decreases his appetite. I heard from so-and-so down the street. My answer is, and I don't mean this glibly, but so what? Okay? If his appetite is decreased for a day, for 2 days, that's for lunchtime, that's not going to kill him. We can always stop the medicine and we're back to where we started. Like no harm, no foul. But if it's lethal, irreversible, or very painful, then I'm more concerned. Okay, last about evaluating risks is that you all see kids from neonates up to adolescents, and as you know, they are different and they react to medicines differently. So that, for example, age is important. The stimulants cause the younger kids, the little kids, nursery school kids, to be irritable much more so than the older kids. The dose is important, the duration is important. And I just want to make one kind of put a spotlight on the whole issue of metabolism, things that I saw there was actually a lesson, a lecture on, I think maybe later today or tomorrow, about genomics. And, really the frontier here is that, we're learning about the different liver enzymes. And as you'll see in a few minutes, some of our medicines in psychiatry affect those liver enzymes, and you have to know that. I think one can never memorize all the interactions, but you just have to know that they exist. And I'll point out 1 or 2 places in psychiatry where they exist. Okay, so one of the things that I'm going to surprise you with, I have some door prizes. So before we get to talking about the medicines, I have a door prize for this question. So the story of Obertrol. Obertrol was a medicine used back in the early 60s. And can you tell what it was used for? Weight loss. Obertrol, exactly. Obertrol was, that use of it fell out of favor. The company got sold, and a few decades later actually, they renamed Obertrol as a medicine, and for a door prize book, okay, you have to raise your hand though. Who knows what that is? Shoot. Say again? Adderall. Okay. So the point is, there you go. So the point is, you want the giving of the book? So the point is that when you can't sleep at night tonight and you're thinking about, do you mind if I stay down here? Is this good? Okay, because I feel distant up there. So the point is with Obertrol that when is a benefit and when is it a side effect? If you look at Obertrol, appetite suppression 50 years ago, that was the benefit of the medicine. Now it's called Adderall, and appetite suppression is the bane of my existence because all the parents are complaining to me that the child has that side effect. And so there's kind of an interesting philosophical question in here. Actually, I left my watch up there. So just one word about FDA, because a lot of times people are curious about this. To get I don't know if you know this, but to get approval, a drug company develops a medicine, they put it to the test. They have double-blind placebo-controlled studies. They have side effect studies. They go to the FDA and they say, here's, our medicine. And the FDA looks at all the data and says, either yay or nay. And once they have that approval, they can go and advertise that medicine for that particular purpose. If it's used for anything else, it's off-label. Now, do you have any idea what % of the medicines that you all prescribe, not that I prescribe, okay, that you prescribe, because a lot of you in general pediatrics, what % of the medicines do you think that you use are off-label? What do you think? Shout a number. Yeah, like 70. Okay, you know what? I think that gets a book. Yeah, like most of the medicines you use are off-label. That again has to be explained to parents. No picture. That again has to be explained to parents because they don't really understand that. Okay, we are 6 minutes behind, but we're good. We're going to get. But I'll spur the horse myself. Okay, so ADD. Now, I want to make just a couple of quick introductory comments about ADHD. First, you know what ADHD. ADHD is the little 7-year-old boy who is bouncing off the walls and flying from one chandelier to the next and can't pay attention to the teacher. We all know that. What we're learning, though, is that ADHD is more common. Girls don't always look that way, but they have ADHD. There's kind of an emotional impulsivity to a lot of these girls. I find that a lot of the ADHD girls have difficulty in early adolescence. They're messing up socially because their impulsivity is just kind of driving the girls around them, kind of crazy, and so that causes that difficulty more than they are hyperactive. So ADHD has a lot of different faces, but what you always want to look for are the signs and symptoms of ADHD. You want to look for them in more than one setting. You want to look for them over the course of time, from less than now 12 years old. And you want to make sure that there's not another cause. Now, not another cause is, I think, extremely important for you all, because now and then, I will find a child who has a seizure disorder. Okay, if you're in general pediatrics, you're going to see them far more than I do. And what I always do, amongst asking about encephalitis and meningitis and just all the general questions, is I always demonstrate a petit mal seizure. While I'm talking to parents, I will explain to them, that it's a lapse. What was I saying? The reason I'm doing that is because I find that very effective. And granted, most of the time, parents say, "Oh yes, I think he did that." It's not a petit mal seizure. He was just, watching SpongeBob or something, But once in a while, you actually pick that up. So you want to look for the things the medical reasons that say why it's not ADHD. Okay, now, so we know ADHD is this kind of biological disorder, but there's kind of an environmental side of this, and I just put this slide in just to point out, because the environmental, the ecological view of ADHD. So in this study, they looked at the oldest kids in the kindergarten and the youngest kids in the kindergarten. And what they found was that the rate of ADHD was higher, was roughly twice as high for the oldest kids for the youngest kids in the kindergarten. And it's changed when they changed the cutoff date of kindergarten. Basically the same principle. So this is an interesting slide that I just want to kind of make you aware of, because it's not always ADHD. Sometimes Johnny is just too young, compared to the other kids. When you're 5 years old, 10 months is 20% of your life, of development. Okay, and the other study, before we get into the medicines that I wanted to point out, was this study of the ADHD spectrum. This is the frontier. This is a study from NIMH like 2 years ago, I think, and actually it's more than that. And what they did is they took 4 groups of kids kids with ADHD by the book, kids with lots of ADHD symptoms but not ADHD, kids with a few symptoms, and kids with no symptoms. And what they showed was that the kids, they looked at pruning, at how quickly they kind of pruned their synapses. And what they found was that the kids with no symptoms pruned the fastest, followed by the kids with some, kids with a lot, and the slowest were the kids with ADHD. That's important because it points out what a spectrum ADHD might be, kind of a biological spectrum. It's not necessarily a categorical diagnosis like pregnancy. You're in and you're out, or you're out. That's the way we used to think of it, but it's probably not that. And that's going to complicate your treatment and your use of medicine, because the question I think will come up is, who do you use medicine for? You're like, where on the spectrum? Are you going to look for DSM-5 diagnoses, or is it okay if it's not quite? Okay. It also means that a lot of those kids with some symptoms, and maybe even with full-fledged ADHD, as we know, as they mature and their synapses get pruned, they're going to have fewer symptoms, and they're going to kind of sense get better. It's kind of like, having an arthritic gardener, doing your shrubs, okay? It'll eventually get done, but it just takes a little bit longer. And that's actually optimistic, I think. Okay. The last thing about ADHD is that you need to know these kids probably better than anybody else, because they come to you with lots of things besides ADHD. The rate of ER visits and outpatient medical costs, the rate of STDs, the rate of early pregnancy, the rate of cigarette smoking, et cetera, all those difficulties are greater in ADHD kids. And that's, I'm guessing that, a lot of the kids you see who, you may or may not have, you may see as ADHD or not, it may never have been identified, but if you look carefully at those kids with high-risk behaviors, you're going to find a lot of ADHD kids. Okay, what do we do about ADHD? Medicine, which we're about to talk about, is the mainstay. Is there a role for behavior therapy? Yes, there's a role for behavior therapy in kind of, young kids with simple ADHD, and if you want to try that, that's, terrific. Or, kids who have a lot of oppositional symptoms, that's important, to do some behavior therapy. But really, nothing changes the ADHD child like medicine does. That's just the way it is. Now, so what are the medicines for ADHD? There are 3 FDA-approved medicines for ADHD, groups of medicines. The first are the stimulants, and then atomoxetine, which is Strattera, and then the alpha agonists. We're going to spend most of the time talking about the stimulants because they're number one, more effective, than the others, and because they've been around for decades, and so we know more about them than we do the others. Okay, so a little bit of history about the stimulants. So how was it discovered that the stimulants work? So in 1937, Dr. Bradley, who worked in Rhode Island, you can see another free book coming, who worked in Rhode Island, was using Benzedrine and for something. Now, the question is, what was Dr. Bradley using Benzedrine for? Wait, go ahead. I can't hear. Nope. Whoa! Asthma. Okay, that deserves a round of applause. I have, that was, you're welcome. That was well done. So he has this asthma medicine, kind of asthma, allergy, respiratory medicine, and he gives it to these kids at this, like a kind of residential school in Rhode Island, and he notes this spectacular improvement. And with that, the stimulants are on the map. Okay, not really used more until the 60s, and then over the past roughly 30 years with long-acting medicines, even more so. Now, if we take the stimulants, the whole family of stimulants, the truth is that I've had many kids on the long-acting medicines who don't get optimal duration. Sometimes they get shorter duration, and I'm not exactly sure why that is, but it is. And I tell parents that the longer acting the medicine, the less that you should trust my numbers of duration. Okay? So you can trust when I say that a Riddle tablet's going to last 3 or 4 hours. you can pretty much bank on that. But if I say that a long-acting medicine is going to last, 9 to 12 hours, I think that's iffy. Okay. Basically, they're equivalent, but you have to have equivalent doses. I put this in just for your kind of edification. Now, how do the stimulants work? So the basic view is that they increase norepinephrine and dopamine in the synapse and in the frontal lobes, maybe in other parts of the brain also. And the point really of this slide is that if you look carefully, methylphenidate and amphetamine actually work differently at the synapse. They're not exactly the same. And I think that's important because you'll find that some people respond to one of the stimulants, and some people respond to the other. So some people, in other words, respond to methylphenidate. In fact, if you put your hand in the hat and you pull out either amphetamine or methylphenidate as your first trial medicine, you'll find that you'll have about a 70% response rate. For those who are not responders, in other words, the 30%, if you give them the other one, about 70% will respond. So your yield goes from about 70 to about 90% by using both. So if medicine number one doesn't work, it pays to try medicine number two. And lastly, and this is also something that I explain to parents, is that when the medicine works, it has a slow increase in dopamine and norepinephrine, particularly dopamine. When you get a rapid increase in dopamine, for example, if you snort your Adderall, then you get a rapid increase in dopamine in the synapse, and in various parts of the brain, that feels good. And when that feels good, you want to do it again. So there's a big difference. One of the reasons that these medicines are not addictive in kids who use it in a reliable, responsible way is because they're having a slow increase in, walk down here. They have a slow increase in their dopamine levels, not that rapid increase. Okay, so what does the stimulants do? What the stimulants do, their most powerful effect, and it is probably as dramatic as anything that you see in medicine, is to decrease impulsivity and hyperactivity. So when you have the hyperactive 6-year-old boy and you give him a stimulant, and 30 minutes later he's sitting there, drawing a picture in detail, of SpongeBob, then that's very dramatic. The second most important effect is that it improves focus and decreases inattention. But then there's a whole lot of, if you want to call it the icing on the cake effects, decreasing aggression, getting more thumbs up from your peers, okay, more socializing, improving, teens driving. I mean, that's an important effect. Improving academic performance, at least in the short run. In the long run, that's a longer discussion that we're not going to have now, and perhaps a little bit more debatable. But we know that the stimulants do, most importantly, decrease impulsivity and hyperactivity and improve inattention. It's worth noting, and this kind of gets us back to the philosophical discussion about spectrum disorders, is that the stimulants do that whether you have ADHD or not. In other words, instead of your cup of coffee this morning, okay, if I would have given you at 7 o'clock, before you realize what a stimulating discussion this was going to be, and you're kind of dragging in and you say, if I would have just left you a stimulant on each of your chairs and you took it, then you would all be more focused on me now, okay? Why I didn't do that, I don't know. Okay, so actually Shakespeare used to bore me to death, but with a couple of Riddle in, I can see the underlying psychosexual conflict in all its lyric and socio-political significance. So, does the medicine work? I mean, he obviously thinks so. The truth is that if you look at double-blind placebo-controlled studies, there are hundreds, literally. This is a given at this point. However, a lot of your patients don't have simply ADHD. They have ADHD and they have a whole bunch of other things, and that's going to complicate our lives. Okay, so what I chose to do here is just have a couple of slides on a big study not that proves that medicine works, okay, because there's no placebo group in this study, but this was the big government-sponsored study of stimulants, the MTA study, and they had 4 treatment groups. They had medicine and behavioral treatment by the research team. They had methylphenidate only, they had behavior therapy by the research team only, and then they had community care, kind of business as usual, you know, by folks like you and me, okay, and the pediatrician, and, you know, just kind of giving meds. And what they found is that combination therapy works best. In other words, medicine plus behavior therapy works best, but it was really followed very closely by medicine alone. The point being that medicine alone is really the mainstay treatment here. However, what they found is that in the community care group, okay, that about 60, I think was percent of those kids were taking medicine. In other words, you and I and the local pediatrician were giving these kids stimulants, but they were not responding anywhere near what the research team. Why is that? Well, the reason is because community care providers don't use a sufficient dose of medicine. Now, granted, this is back with the old tablets, okay? This is kind of, the study, the kids in this study were not on long-acting medicines that have become the kind of the mainstay these days. But they were using higher doses, 30 milligrams instead of 20 milligrams a day, and the research team doctors were giving them 3 times a day instead of twice a day. And they were following up with, instead of, you know, what the community care was getting was 17-minute follow-ups twice a year. So it's not just about writing a prescription, okay? It's about follow-up, it's about having interaction with the school, it's about using sufficient doses and not stopping short. A lot of people will dose the stimulants by going until they hit side effects, kind of within reason, and then backing up. Okay, so they see how far they can go because they don't want to stop short. Okay, now, how about other populations besides your just general kind of older ADD child? Well, that should be changed actually. The PDD is now ASD, so what used to be pervasive developmental disorder, the autistic spectrum. Those kids can also use the stimulants, but they're not as effective, and they're more prone to side effects. Okay, so you have to be a little bit more careful with them. As with the preschoolers, same thing. You can use them, but you have to be more careful. They're going to have more side effects, more irritability, and they're not going to be as effective. And I put a note in here about substance abuse, just because a lot of times you have a teenager with substance abuse, and you know, you do a history and you say, you know what, I think this adolescent has ADD. We should start him on a stimulant. And everybody goes in with the hopes that if we start the child on the adolescent on a stimulant, that the ADD gets better and they stop using drugs. Wrong. It's really just doesn't work that way. The way you have to do this is by treating the drug abuse first. And then once that's treated, if you find ADHD, perhaps you treat it. But don't go in hoping that the stimulant is going to make that big a difference. Okay, so here's my kind of practical guide for using the stimulants. I pick a stimulant, in other words, a family, either the amphetamine or the methylphenidate family. As a rule, I pick the methylphenidate family first, personal preference. My thinking is that I have more choices of types of medicines. You know, I have a patch and I have a variety of different durations, and I like the very short-acting methylphenidate tablets. I like having that at my disposal. Start at the lowest dose. I try the patient, the child on it for 3 to 5 days. Now, why 3 to 5 days? It doesn't have to be 3 to 5, but 3 to 7. Why? 3 days, I want a minimum of 3 days because anything can happen in one day. Okay, you start the child on medicine and he comes home and he's had the best day of his life. Okay, well, did he have the best day of his life because he's on medicine, or because they were talking about Tyrannosaurus Rex that day And he happens to be the world's expert on Tyrannosaurus rex. So one day, I'm not convinced, neither for benefit nor for side effect, to tell you the truth, okay? 3 days already we have a pattern. So I like a minimum of 3 days, but I like pressure. I mean, I don't want to sound, you know, callous and uncaring, but that's kind of the cost of doing business with any medicine. Slight increases in pulse and blood pressure, frequent. Almost virtually everybody gets a slight increase. If a pulse goes from 84 to 90, though, no pediatric cardiologist is really worried about that. On the other hand, probably less than 10%, some places in the single digits, of the kids are outliers. So they might go from 80 to 110, or from 80 to 120, or maybe even 130. And, you know, I mean, pulses go that high when the child is playing soccer. So again, I don't think the cardiologist is going to worry about that. But I want to know if I'm giving a child a medicine that's causing their pulse to be, let's say, 130 for 8 hours a day, I want to know that. Because I want to talk to the pediatric cardiologist and say, what do you think? You know, is this, because some people are not comfortable. Sometimes they're comfortable when the pulse is, as long as they know it comes down again. But I want to know that information. So I kind of follow pulses and blood pressures. Next side effect, decreased appetite. Common, let's call it 50% of the kids will have a decreased appetite. Usually for lunch, you have to work around it. You know, the college kids are mature enough that, you know, they take their medicine and then they know they're not going to eat, you know, for 4 or 6 hours, and then they eat. You know, so that's college kids. But, you know, the middle school kids have lunch at 10:15, okay? And, you know, they're not hungry. Well, we have to work around that. A lot of times they'll have, you know, a big snack when they get home, or they'll have a big snack and then they'll have dinner after their snack. Insomnia. If you give the stimulants at bedtime, you know, then you can drive, you know, from Vegas to Seattle, okay? And I'm sure that truck drivers, you do that so that they can drive from Vegas to Seattle. But most kids don't take it at night. They take it in the morning, and except for some kids, some of the very long-acting medicines generally do not have a problem with insomnia. If they do, you have to try to move the medicine earlier. You have to try to use a shorter-acting medicine. Most kids don't have that. Now, here's a little pearl that I will throw your way, which is that now and then, everybody has given an ADHD child a stimulant at night, okay, which is counterintuitive. And the reason is that once in a while, the ADHD medicine, the stimulant, will help the child kind of settle so that they can sleep, okay? Again, counterintuitive, but now and then it works. Now, there are a couple of controversial topics that we just have to touch on. One, the sudden cardiac death, quote-unquote, controversy. Okay, long story short, there's been some research on this over the past roughly 10 years. Some of the studies have shown that there's no, first of all, it's a tough thing to study. It's tough to study because it's the rare event. It's hard to study the rare event because it happens rarely. But what some of the big studies have shown is that the kids on stimulants, that there's no association between any kind of sudden cardiac death and the stimulants. There have been one or two, I can think of two studies that say, well, not so fast. You know what I just did? I just pushed a button on this little digital watch and I have no idea where I am. So this is useless now. So you know what? Somebody put up your hand in 5 minutes or less. So some of the studies, though, two in particular, show that maybe, yes, maybe there is a connection between stimulants and sudden cardiac death. That being said, what the research shows is that even if there's an increase in kind of relative terms, the absolute increase is still very, 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 very slight. Okay, so you know, if something goes from, you know, a risk of, and I'm just putting numbers out there, don't take these too seriously. If the risk is, say, 1 in 100,000, and it goes down, and it goes up to 1 in 50,000, that's a double the risk, okay? But it's still 1 in 50,000. I mean, the chances of your seat collapsing under you are probably greater than 1 in 50,000. So you have to put this in perspective. Some parents understand that, and you can explain it. For some parents, it's difficult. That said, if a child has a personal history of any kind of cardiac, certainly congenital cardiac disorder, arrhythmias, unexplained fainting, or a strong family history of unexplained fainting, sudden death, strong history of arrhythmias, I send them to the pediatric cardiologist to get they're okay. Now, there are a lot of gray zones here. What do you do with adopted kids? Where you don't have family history? There's no great answer there. How close a family history? What if grandpa has, a history of atrial fib? I don't know. Nobody has the answer to that. But where there's a strong enough history, I just find it prudent to be careful with that. Okay, next, height and weight concerns. If you give the stimulants at a reasonable dose, and let's just say that's a height and weight curve, and let's say we start, so it's going up, and we give the stimulant right at my wrist, then what you'll find on average in the big studies, if you look 2 or 3 years later, you will see this. And I'm going to exaggerate it so you can see. Like that. You see that? So the kids are still growing, but on average, 2 or 3 years later, they're roughly an inch shorter of what they might have been. Now, what everybody agrees on is that if you stop the medicine, the kids catch up. I mean, assuming that they're not 19 years old. Okay, as soon as they're still growing, the kids catch up. So no problem. And there's some evidence that the kids might catch up even if you don't stop the medicine. And I have certainly seen this with weight. I see a lot of kids who dip, their weight kind of dips, and I continue the medicine, and then a year later they've kind of caught up on their own. So but it's something that has to be followed, and I take heights and weights every 3 or 4 months. Whoops. Tics. Long story short, tics, it used to be thought that tics and the stimulants were connected, that they might be. The research seems to show that they are not connected, that the stimulants neither cause nor exacerbate tics. Now that said, the research is only on so many hundred kids. Okay, and so let's say it's 1 in 1,000. Everybody has seen a child who they are sure the tics got worse on the stimulants. So it might be. So you have to be careful of that, but it's really not a reason not to use the stimulants. Okay. And actually, and that might be truer, well, what the research seems to show is that there's less of an effect, or there's no effect, from methylphenidate. Amphetamine, the window is open a little bit that maybe tics and the amphetamine have a connection. So, for whatever that's worth. Addiction and misuse. Are the stimulants misused? Absolutely. Okay, there's no question about that. Talk to your college kids and ask them what % of kids on their college campus take stimulants that they get from their friend. I have heard all sorts of numbers, and again, I think that's worth a long, interesting discussion. However, do kids get addicted to the stimulants? When parents come in and they say, I'm afraid that he's going to get addicted. No, I've never seen that. When you use the medicines responsibly, you don't get addicted to that. Now, do polydrug abusers abuse, and can they get addicted to the stimulants? Yes. Okay, but that's really a different kettle of fish than certainly I'm treating in my office. Quick question. Oh, 5 minutes. So what time is it now? 8:03. Okay, next. Priapism, I'm leaving that out. That's like they just came up with that, anyway. Strattera. So Strattera is not from the stimulants. We're now in number 2. group number 2. A group of 1, it is a selective norepinephrine reuptake inhibitor. It's different than the stimulants in part because, number 1, you have to use it every day. The stimulants work when you use them. Okay, you give it at 8 o'clock, at 8:30 it's working. I mean, basically that's it. Strattera, you give on January 1st, you give it on January 2nd, on January 3rd, etc., and then after 3 or 4 weeks, it works, and for some people, it even takes a little bit longer to work, but you have to take it every day. Some parents don't like that idea of taking medicine every day. And the response rate is not as great. You know, if I said 70 to 90% with the stimulants, with Strattera, it's only about 50%, something like that. Now, one of the benefits of Strattera, there's some evidence that it might also help with anxiety. Interesting, and just worth noting. The other interesting thing is that, remember I said that with the stimulants, you start at the lowest dose. Let's just pick methylphenidate 5 milligrams. You use it for your 3 to 5 days, and then you go to, say, 10 milligrams and for 3 to 5 days, and then you go to 15 milligrams, 3 to 5 days. So you've started at the lowest, and you've gone up, up, up. With Strattera, it doesn't work that way. You can actually go by a milligrams per kilogram basis. And what you're shooting for, you start at something like 0.5, 0.6 milligrams per kilogram, and then you go up to about 1.0 to 1.2 milligrams per kilogram, and that's really the effective dose, and that's where you want to get there after about a week, and then that's where you leave it for 3 or 4 weeks. Now, for some kids, there's some evidence that even going up to 1.8, that's kind of off-label, but but some people go that high, and you can see more of a response at that high dose. The downside of Strattera, sleepiness, sedation, okay, and it tends, and people say it tends to go away. My experience has been that, that after 3 days of mom like pulling Johnny's head out of the cornflakes in the morning, that she says, I just can't do this. Like, I don't care if it's going to go away in a month. It's too sedating, stop the medicine. So that is a problem. There's also some kind of GI issues, although I tend not to, I just generally don't see that. And again, the question of priapism, for whatever it's worth. Okay, next, now we're going to the third family of ADHD medicines, namely the alpha agonists, Intuniv and Capvey. So what Intuniv and Capvey are long-acting guanfacine and clonidine. Okay, now those medicines have been used in child psychiatry for about 30 years now for tic disorders, off-label, catapress in particular, or clonidine in particular for sleep disorders, for insomnia. It's the most commonly prescribed medicine by you guys for childhood insomnia, and for ADHD. About 3 years ago, 2 companies came out with long-acting clonidine and guanfacine, and named them Intuniv and Capvey, and got an approval for ADHD, and it seems to work. Again, not as well as the stimulants, but it seems to work. And what's also interesting is that these medicines have an FDA approval that you can use it with a stimulant. That's a great, so some kids, that's great, especially if the kids are kind of up and down on the stimulant through the day, even the long-acting ones. Intuniv in particular, you take once a day, and it's good for 24 hours, and it kind of lowers the whole river in a sense. And so it's when used with a stimulant, it can be very effective. Capvey, even though it's long-acting, has to be given twice a day. Okay. And the problems with that, side effects, again, if clonidine is used for insomnia, okay, you can imagine it's pretty sedating. So these medicines can be sedating. Again, clonidine, Capvey more than Intuniv, and these are medicines used for hypotension originally, and so you do have to keep an eye on pulse and blood pressure. And in one report, there was a question of QTC interval changes. So again, not to be taken lightly if there's a cardiac history. Okay, where's my timekeeper? What time? 8:08. Okay, we're 8 minutes behind. So, depression. So we're moving on here. Do me a favor, just in about 15 minutes, just scream. Thanks. Okay, so major depression. So I put in the signs and symptoms only because I want to make a distinction between depression and bummed. Okay? Kids get bummed. Okay? Adolescents in particular get bummed. They didn't get into the college they want. They got jilted by their prom date. The girlfriend broke up with them. They get, that's part of adolescence, and they get bummed. That's not necessarily depression. That can become depression. But with depression, you're really looking for this group of symptoms, and you're looking at to have, with, a depressed mood and a kind of an anhedonia, or an inability to enjoy, over the course of time for most of the day, every day for a few weeks. Now, what we know about depression, the good news about depression is that, certainly in adolescence, is that the episodes end. They last a few, 7 to 9 months, sometimes longer on average. But by 2 years, 95% of the kids are better. That's the good news. The bad news is that if you wait a few years, those kids are more prone to get depressed again, and that's obviously a problem. So these are not kids who you can simply, when the time comes, stop their medicine and say, have a nice life. Okay? You really have to follow up these kids to make sure that they're not getting depressed. Now, one of the things that helps help them not have a recrudescence of their depression is to treat the depression fully. Okay, you don't want to be content with, and I've made this mistake. I had a patient once, an adolescent boy who was depressed. I gave him an SSRI. He got a little bit better. I was kind of content. He didn't have side effects. And he kind of went along like that for 6 months. And then he started getting depressed again, and I said, we should up the medicine. And I was more aggressive with the medicine. When I was more aggressive, he got clearly better. And I realized my mistake. I was overly conservative. I mean, I'm conservative by nature. I was too conservative, okay? And it was a mistake, so you don't make the mistake. Okay. How about preschoolers? Preschoolers also can get depressed. Okay, and what you in particular want to look for are those specific symptoms, the inability to enjoy and that kind of being withdrawn, more than just kind of the irritable mood. Irritable mood picks up a lot of preschoolers with a lot of different disorders, but not just depressed, not just depression. The other interesting thing is that what the research over the past few years is showing is that when the preschooler is depressed, it doesn't simply go away. Parents, we all, I think, have this idea that we would like to think, look, he's a child, or she's a child, what's on their head in life that they have to worry about? It's just a stage. Well, the truth is that for some kids it might be a stage, but for some kids it's not a stage. They have depression. Now, just a very few key points about assessing depression. These are just some of the highlights that I look at. I look at, number one, suicide risk, and in particular firearms. I look at, is the child psychotic? If the child is psychotic, then they have 14 times the risk of suicidal behavior. That's a pretty big risk. Hopelessness, I mean, that real sense of there's no light at the end of the tunnel. The inability to enjoy, anhedonia, alcohol and drug use, also family history, because a lot of times with these kids, the parent is depressed, and that presents a whole issue that is important in terms of their treatment that you need to know about. Okay, and again, educating parents that depression carries risk. Okay, to do nothing with depression is to do something, and that can be a problem. So we're always going to be educating parents about what depression is, that it's not a weakness, that it's a biological disorder, but that it is highly influenced by the environment. And so, particularly adolescent depression, I think it's a very messy area, because some kids have, for lack of a better word, a biological depression. Some kids' adolescent lives are just messy. Okay, they got comorbidities, they have messy social situations, and they look depressed, but when you change the environment a bit, they do better. And for that reason, and we're about to look at the SSRIs and their response rates, before you do anything, before you simply write a prescription for an SSRI, it pays to have the child, particularly the adolescent, kind of, as long as they're safe, okay? I'm not talking about somebody who's imminently suicidal at all. I'm talking about the child who is depressed, you're concerned about them, but you think that they're safe. It pays to try them, with a course of psychotherapy, because sometimes that support simply helps, and over the course of time, things get better. Okay, now, with that said, we're going to look in particular at the SSRIs, okay, and we'll have like one slide on these novel antidepressants. Okay, so these are the SSRIs. Now, what I want you to note is at the bottom, the FDA approval for the SSRIs. Only 2 of them are approved for depression, okay? Fluoxetine, Prozac, is approved for child and adolescent depression, and Lexapro, escitalopram, is approved for adolescent depression. That's it for depression, and you're going to see why in a half a minute. There are also 3 of them are approved for ADHD, for OCD, okay? And none of the SSRIs are approved for anxiety, even though in the beginning I said that they were great for the use of anxiety, which again we'll see in a minute, but none of them have an FDA approval for that. Now, I just heard at a conference like 2 months ago that duloxetine is FDA approved for anxiety in children, but I will tell you that I asked one of the academics who was in charge of this conference about that, and she said she didn't know it, and I haven't found anybody who's seen the research on it. I try to find it online, but just for the sake of accuracy, I had to put that in. There is one FDA-approved medicine, although that's not technically an SSRI. Okay, so what are the SSRIs used for? Okay, forget FDA approval for a moment. They're used for all of these things at the top, okay? Anxiety disorders, panic disorder, OCD, depression, not bulimia, not anorexia, and not PTSD. And I put those in particular because, and not trichotillomania, okay, hair pulling. I put those in because we all have a little bit of like an itchy finger to write the prescription because you hope it's going to work, okay? But the evidence for those things at the bottom is that it doesn't work, okay? And I think that the one we feel personally, I feel most, trichotillomania, when kids come in with hair pulling, I have an urge, okay? And the urge is to write that prescription for an SSRI. The data does not support it, okay? Arguably for clomipramine, which is actually a tricyclic antidepressant, which is also used for OCD, but really for trichotillomania, it's behavior therapy, it's habit reversal therapy, which is where you have to go. Okay, what's the party line on how do the SSRIs work? Selective serotonin reuptake inhibitor. That's how they work. They inhibit the reuptake of serotonin. Is that true? Yes, that's true. Is that the whole truth? Probably not. Okay, there's probably more here that we just don't know. How are the SSRIs metabolized? And I want to make a special point of this because the SSRIs are metabolized by those P450 enzymes in your liver. And again, without going into great detail about this, as you know, that's a complicated area, these P450 enzymes. And I will tell you that how can I phrase this? Each of the SSRIs impacts, either increases or decreases, many of the P450 enzymes to a greater or lesser extent. Now, if there are a lot of variables in that sentence, then you heard it right, okay? And because, that's why I keep the little book next to my chair so I can look things up. But you have to know that with the SSRIs, okay? For example, Strattera, so fluoxetine, Prozac, inhibits 2D6. Strattera is metabolized by 2D6. So the child's on Strattera, you add fluoxetine, and after a few months, you start getting Strattera side effects. Why? Because the fluoxetine has inhibited the metabolism of Strattera, and now the Strattera dose is higher than you think, in a sense. So the blood level is higher than you think. So I'm just kind of a warning about that stuff. So half-lives. I only put this in just to point out that fluoxetine, Prozac, has a much longer half-life than all the others, and you just have to know that. For that reason, it's the only SSRI that you can stop. You don't have to taper. When it comes time to discontinue the medicine, you don't have to taper it, 20 milligrams, 15, 10, and so forth. You can just stop it, okay? And the reason is the medicine will taper itself. It just takes weeks to come on down. Okay. Where's the proof? I want to make one very important distinction. Bipolar disorder, which we're not going to talk a lot about, but suffice it to say that bipolar disorder depression is different than quote-unquote regular depression. Okay, if you want to think of it as unipolar, the old unipolar depression. And the SSRIs, it's not clear at all that they work for bipolar depression. Okay, so just remember that. Okay, now let's put that aside. Depression, anxiety disorders, and OCD. So let's just take a look at some of the evidence here. Is my timekeeper? I'm sorry? What time is it though? 8:20. Okay. See, I have those little things at the bottom. I actually thought this out. Okay. Unfortunately, I brought the wrong watch. Okay. So the TADS. Okay. So the TADS is the big government-funded study of adolescent depression. Okay. Again, you'll see this over and over again. 4 groups: combination therapy, behavior therapy, in this case CBT, plus fluoxetine, then fluoxetine alone, CBT alone, and then a placebo group. So this is an important study, and I wanted to spend a minute on it for a second because there are a few things that you have to know about this slide. Number one, does fluoxetine work? Yes. Look at fluoxetine, look at placebo. You don't have to be a statistician, fluoxetine works. Number two, as I said about the Zumba and the coffee, okay, a behavioral intervention and a pharmacologic intervention, when put together, work better than either alone, okay? And you see that. The combination therapy works better, not a lot better, but better. Number two, if you look at even the best treatment here, well, if you look at fluoxetine, it works better than CBT. That's important. Next, if you look at fluoxetine, you can see that it's better than placebo. However, that big number is 60%, okay? That's 60 out of 100, okay? For those of you doing the math, that leaves 40 adolescents, okay, for whom it's not responsive after 12, who are not responsive after 12 weeks. That's a lot of kids, okay, 40% in 12 weeks. That's 3 months. Now, I don't think I have the slide, but if you follow these kids out over 9 months, you'll see that a lot more get better. But are they better because of medicine? Are they better because they're just getting better? And remember that 9 months is a long time to wait with an adolescent who's depressed. Okay, so the medicine is good, but not perfect, hardly perfect. And the other thing, the last point I want to make here, is that look at the placebo, okay? 35%. That's not chopped liver, that's not bad, 35%, okay? That means that a third of kids get better taking placebo. That's why I said in the beginning that when you have a depressed adolescent, again, assuming that they're safe, that you don't want to necessarily just jump to the medicine, unless they're suicidal or extremely depressed, etc. You want to give therapy a chance because a lot of those kids are just going to get better, just with some talking. And there's, in this day and age, that's becoming a little bit of, like talking about wooden ships, but it's true. Okay. Now, if you look at a lot of other studies of adolescent depression, and these are just a slew of them. It's not complete, but it's pretty thorough. you'll just see that word negative lots. Okay, now why are all those studies negative? They're negative oftentimes. It's not clear whether or not the medicine works, but it's not working better than placebo. Okay, the placebo rates in some of these studies are 30, 40, 50 in one sertraline, 59% placebo rate. It's hard for medicine to do better than that, and so the medicine it just can't compete sometimes, and so it can't show that it's better. So researchers are actually trying to find a way to improve the research so that the medicine can distinguish itself if it can. Okay, now the Tortia study. So what time is it? 8:24. Okay, so the Tortia study basically looked at kids who were not responsive to one SSRI and showed that if you used another SSRI or Effexor, that another 40–50% of those kids got better. So the point is, if at first you don't succeed, try again with another medicine. Don't just give up on the medicine. Okay, now, so you've started your adolescent, let's say, depressed adolescent, on an SSRI. How long do you keep them on it before you know whether or not it works? The SSRIs take 3–4 weeks and sometimes longer to work, okay? And so you don't just run the dose up in that first week, okay? You have to give them a reasonable trial of, and again, this depends on the clinician, based on your, some people are kind of gutsier than others, some people are more conservative than others. But certainly, a couple of weeks at one of the lower doses, and then if there's no response, then you start going up. But you don't want to go too fast because you don't really want to pass a dose that works, and you might not know if that dose works for a few weeks. And so that becomes a little bit frustrating, but that's just the way it is. It's also important to know that, to explain to parents, that it's not just about the dose, it's about the duration. Okay, so sometimes, even at the lower dose, if you give it long enough, the medicine will start to work. Again, in this day and age where everything is snap, 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 and you hospitalize a child for 13 hours, and they get started on medicine and they expect it to work, like that's just pharmacologically ridiculous. But that's kind of the world we live in. Now, once the child has responded to the medicine, how long do they stay on it? Someplace around a year, okay? It's like, this is not medicine that you would use for 3 months, okay, as a rule. Why about a year? Because we know that an episode of depression lasts about a year. So if you start measuring when the child is clearly getting better from the medicine, and from there you measure out, I tell parents about 9 to 12 months, and then you stop it, generally the episode of depression will be over by then, and you're kind of out of the clouds. Now, what I do, though, is, as a rule with these kids, is I don't simply taper it. Whenever you stop the SSRIs, except fluoxetine, you have to taper them, okay, in notches over the course of, let's say, 2 weeks, roughly. I generally don't do that, though. As a rule, because I want to follow these kids anyway. So if the child is, let's just say, on fluoxetine 20 milligrams and doing well, and it comes time to decrease it, I might decrease them to 15 milligrams. How do I do that? Either if they have the tablets, you can break a 10 in half and get a pill and a half, or because fluoxetine has such a long half-life, little pearl, you can go 2 pills one day, 1 pill the next, 2-1, 2-1, and you're good, okay? Because it averages out to 15 milligrams. But I do that for a few months, maybe, and then down to 10 milligrams for a couple of months. So I'm following these kids now and then, and I gradually take them down. Okay. Now, the anxiety disorders. We've got to divide the anxiety disorders into basically the red and the green. I'm not going to talk about those in black. I'm going to talk about the red and the green. The red are all red because a lot of times those three tend to hang together. If you have one, there's a good chance you have another. If you have two, there's a good chance you have all three. Separation anxiety disorder, you know, okay? You know, these are the kids who simply will not go to school because they're not leaving the house. Social phobia, think of as extreme shyness, okay? Painful shyness. The kids who won't talk in class. The kids who won't, you know, they'll talk to their best friends, but they won't talk to anybody else. Generalized anxiety disorder, think of as just kind of the overall worrier. You know, the person who is just continuously, as one child said to me, I worry about anything that crosses my desk, okay? And with that, you know, he had, you know, belly aches and headaches and just all the other somatic symptoms. So those three things hang together, and then there's panic disorder, which we'll talk about in a minute. So first we're going to address the top three. Now, I put this in because those of you in general peds clinics, okay, might not, you know, you're not always looking simply for the things I'm talking about, you're looking for the whole child. If in this study, when you looked at kids at a GI clinic, those with functional abdominal pain, okay, as opposed to those with a clear etiology of abdominal pain, you found that those with functional abdominal pain, 50% of them, okay, had a risk of anxiety at that point in their lives. So when those kids come in with belly aches, you should be thinking anxiety. Okay, don't forget everything else, of course, but anxiety should be on your list. It should be, though, I will say, at the bottom of your list. In other words, rule out everything else, but if you've ruled out everything else, anxiety is a very reasonable thing to put there. Okay, oops, look at those, it's all messy. So this is, one other point about when you're looking for anxiety, and I'm reminded because John Walkup, who did this study, when you hear him lecture, he always says, and I think his point is well taken, that if you go back to your office and you find that you have a lot of ADHD kids and no anxiety disorder kids, you've probably missed the anxiety disorder kids, okay? A lot of the anxiety disorder kids look like they have ADHD, and we have all, and I will be the first to raise my hand, make the mistake of saying, I think it's ADHD, I'm going to treat the ADHD. You treat the ADHD for a few months, and then you say, you know what, I think I blew it. I think it was wrong. This is an anxious child, not an ADD, inattentive type child. So you have to be careful with that. Now, this study, and I apologize for this, numbers all over the place, again, NIMH study for groups, and in short, what you can see here, there are really, I think, two real conclusions. Number one, medicine works better than placebo. Number two, CBT, cognitive behavioral therapy, and medicine work equally well. Okay? They are, the 55 and the 60 are statistically the same. And so there's a place for CBT here. When you have an anxious child, again, to write the prescription is easy, but not necessarily the best thing to do right off the bat. You want to start with cognitive behavioral therapy. Now, that said, you need some things. You need a good cognitive behavioral therapist, not easy to find. You need the money to pay the good cognitive behavioral therapist, not easy to find. You need the time to put in to pay the good CBT therapist, not easy to find. And last, you need the willingness of the patient and the parents to undergo CBT. But if you have all those three, it's very effective, and I always tell kids, and it stays with you for the rest of your life. You know, different than necessarily, one of the SSRIs, which hopefully I can get you off eventually. What time are we at? 32. Thanks. Okay. Now, OCD. The point, you know what OCD is? Kids who are checking, who are washing their hands repeatedly, and they come to you with, with raw hands. Kids who have to confess over and over again, kids who have counting rituals so that they have to go back 3 times before they go back. And what parents oftentimes do with these kids is they engage them, they reinforce their compulsion by giving in. So if Johnny says, I can't get over the threshold of the door because I have to do it just so, but you can pick me up and carry me over the threshold of the door, Mom generally says, okay, we got to get to school, I'll pick you up. Well, that's the wrong thing to do because it reinforces the behavior. It gets them to school, but it reinforces that, and a cognitive behavioral therapist will kind of, work that out so that that's no longer happening. A point being, these kids with OCD can be very secretive. They know that what they're doing is kind of ridiculous, if you will, silly, purposeless, and yet they know they have to do it, and it feels crazy to them. So you kind of have to be very gentle in asking about these kinds of things. Now, again, another government-sponsored study. And in short, from this study, what we see is that placebo doesn't work in OCD. Might work in depression, does not work in OCD. And that the CBT works equally well to medicine. Again, the 21 and the 39 are the same. Don't ask me, I'm not a statistician, but they're equal. And that both together work well. Now, this is an open study. It's not a double-blind study, but I put it in because it's very interesting. It shows that, or at least in an open study, that citalopram, which is Celexa, when you give it over the course of time, the kids with OCD get better, and they don't plateau until after a year. Okay? That's pretty amazing. So when I said it's about duration, not just dose, there actually might be something to that. Okay. So in total, what we find is that the SSRIs are most effective for the anxiety disorders, but not FDA approved. They're also effective, and some are approved for OCD and depression. Okay, what are the side effects of the OCDs, of the SSRIs? Again, the usual suspects. Somebody's going to get a bellyache. Some kids, I've had a couple of adolescents who get sweating, okay, and that's kind of a non-starter for an adolescent. Some kids will get vivid dreams, not really nightmares, but just very vivid dreams. That can certainly be problematic. The big one here is activation. If you give the SSRIs too fast, especially to the anxious kids and the kids with panic disorder, you can activate them. Okay, it's like taking them into Starbucks and shooting them with an IV of a grande whatever, okay? And that's a problem. So you go slowly with the, I find particularly with the anxious kids. Next, that about 10% of kids will get activated. So that's not an insignificant number. Hypomania, which is really mania, just like bipolar disorder, but it's not bipolar disorder, is much more infrequent, down around 1% or so. And those kids just look very bizarre when they get that. Apathy, you can see over the course of time, kids will decrease their anxiety, and in some of them, keep going. Well, you know what? God gave us anxiety for a reason, okay? And we don't want to abolish it, okay? That's not really in the child's best interest. And sometimes if you lower the dose from that who cares attitude, they can kind of come back up and care a little bit, and still have lost that significant anxiety that they were having before. Decreased sexual function, not a problem with children, can be a problem with adolescents, can certainly be a problem with college kids. It's probably the most frequent reason why adults stop their SSRIs. Okay, guys have difficult. Some of them, although I've never, I think, ever seen this with an adolescent guy, kind of loses interest. That I've never seen. But I've seen kids who have difficulty kind of maintaining an erection, or college kids who have a delayed ejaculation, and that can be either problematic, or as one college kid told me, or not. Okay. Next, the bleeding and easy bruisability is again one of those kind of rare side effects, and you have to watch cardiograms. Okay, once you have to watch cardiograms, like red lights go off, and that's kind of LIV. Remember, lethal, irreversible, very painful. And tofranil is still FDA approved for enuresis, but I don't really see it being used very much. I don't know if, is anybody, you're using it? You do? Okay, okay. So there it is, FDA approved, and it is used. I don't hear pediatricians using it a whole lot, I guess. But yeah, that might be. That might actually be. Okay, next, panic disorder. Time? Okay, we're right there. Almost. So panic attacks. Panic attacks in an adult is that feeling of all of a sudden getting that, oh my God, I'm having this overwhelming anxiety and I got to get out of here because I think maybe I'm having a heart attack and my chest is getting tight and I can't breathe, and please get me out of here and get me to a window and give me a drink of water and get me to the emergency room. And then it ends after about, let's say, 20 minutes, 30 minutes, something like that. That's your kind of classic panic attack. Children also get panic attacks, but they don't have always that kind of classic presentation with all those clear somatic symptoms. They don't say, I'm going to have a heart attack. But they do get it. They do get panic attacks, and they do have anticipatory anxiety about having their next panic attack. And when they do that, they don't want to be someplace where they're not safe, like school, because how will I get home, okay, where I'm safe? And so you have to be careful of these kids. They, they have oftentimes what I call, this is kind of mine, the positive water bottle sign. These are the kids that always have that water bottle in their hand and they're always sipping. Okay, not all kids who drink water have panic attacks, but you look for some of them. What they're doing is they're swallowing, making sure that their throat is patent and open, and that they can breathe, and that they're not choking, and they can be very subtle about it. They're also kids who are very aware of their bodies, which makes it difficult, okay, because they feel everything. So you start them on medicine, and you know what? I think my right lower rib has a little bit of a pain in it. I wonder if that's from the medicine. They're just constantly aware of everything in their bodies. So it's a challenging group to kind of walk through in terms of treatment. You don't want to treat them too slowly because they never get better, but you don't want to treat them too fast because you get a side effect and then they're out the door and never to be seen again. Okay, so the treatment of panic attacks is mostly cognitive behavioral initially. Okay, you want to, again, educate, you want to teach kids about panic attacks, but if the panic attacks are bad, you can use either a benzodiazepine, okay, but we have to be careful with that, as we'll talk about in a minute, and that will stop the panic attack kind of in its tracks now, acute treatment, or prophylactically, you want the child on an SSRI. Now, again, no research in kids. This is borrowed from adult literature, but it's right now all we have. So in terms of the benzodiazepines, I mean, these are the three that I find most commonly used. In terms of, they decrease anxiety quickly, but what you want to be careful of is in adolescence, obviously sedation, driving can be a problem. For younger kids, paradoxical activation. Sometimes parents will want a benzodiazepine for the child who has a flying phobia and they have to fly to wherever, okay? And I always tell them, I said, I'm going to give you this, but don't try it for the first time at 30,000 feet, okay? Try it on the ground, okay? If it works, okay, but I don't want to cause an activation at 30,000 feet. That can make for a very long plane ride. The last thing I'm going to talk about here for a minute is just the decrease in motivation for exposure therapy, so that if you decrease somebody's anxiety, there's less traction for cognitive behavioral therapy. Okay, that's kind of a paradox. And I've had colleagues of mine who are psychologists call me and say, you have to lower the medicine, okay, because I don't have any anxiety to work with. Okay, you need some anxiety if you want it to get better. Okay, so now, the antipsychotics. Time? Oh, 5 minutes behind. Okay, so there were the old-time first-generation antipsychotics. These are medicines like chlorpromazine, thorazine, Haldol, things like that, that are still FDA approved for tic disorders like Tourette's, okay? But they are really not used a whole lot. They've been supplanted by the second generation antipsychotics. And my understanding from last year is that you guys don't do a lot of this treatment, so I'm going to move just a little bit faster here. The good news about these atypical antipsychotics is that they minimize the extrapyramidal side effects, the movement disorders, in particular tardive dyskinesia, which was an old, potentially irreversible movement disorder. Okay, irreversible, L-I-V, that gets my attention, decreases it. The bad news about these, okay, the bad news about these is that they cause weight gain, okay, and it can be significant weight gain, and that's going to fall in your lap, okay? These are the kids who need to have their weights monitored, cholesterols, triglycerides. They're more at risk for diabetes. In one study, they were at risk for diabetes. They had, I think, 2 or 3 times the risk for diabetes, even a year after stopping the medicine. What that's about, I don't know, but clearly that's an important side effect. Let me just go back for a second. So these medicines are approved for schizophrenia and bipolar disorder, okay, but also over recent years, but an earlier FDA approval was for irritability in autism, and they were, you can see, you can see from this study that in autism, for that extreme irritability, the kids who are biting their hands and you know, being very aggressive, the medicine really, really works. But again, you want to keep the dose low and watch for side effects. Okay, we kind of talked about this. But it's significant weight gain. Okay, so this is a store called Lithium. Anybody want to take a guess where it is? Estes Park, Colorado. And I went in there and I said to her, I said to the woman, I said, like, what's the deal with this name? She says, I don't know where they came up with the name of the store, but you're the second psychiatrist this month who's asked. Okay? I'm not going to take the time to talk about bipolar disorder. It is a long discussion. Suffice it to say that, yes, it has been overdiagnosed by a gazillion percent over the past decade, that what you're looking for are episodes, okay, of bipolar of manic symptoms, and you're looking for real clear euphoria and excess silliness, et cetera, et cetera. Okay, that said, again, I'm just going to go through this quickly. You know, that said, the mood stabilizers are used to treat bipolar disorder. And these are your classic mood stabilizers, starting with lithium. The problem is that, in a summary, is that do they work? It's not clear that they really work very well, okay? And they come with, all of them come with significant side effects. So if you look at the use of the second generation antipsychotics that we just talked about 2 minutes ago, the evidence that they work for bipolar disorder in adolescence is clearly better than for the mood stabilizers, and you don't have some of the side effects that from taking lithium or from taking Depakote, like the question of polycystic ovary. Okay, next, tic disorders. So what you have to know is that when you're talking to parents, and this is kind of a take-home for parents, is that picking your nose is not a tic, okay? And again, you have to demonstrate them, and I always, show parents, kind of the classic eye-blinking tic, the nose squinching, and all these. I show them because otherwise what happens is that habits gets fuzzy with tic disorders. So that's kind of point number 1 about tic disorders. Point number 2 is that tic disorders, when it's a truth, about 20% of kids will have a tic at some point in their childhood. By the time they're in 6th grade, about 20% of kids, 25%, will have a transient tic. Okay, so that's kind of normal, almost. But of a much smaller percent will really have Tourette's or an ongoing chronic tic disorder. The chronic tics tend to peak around 10 or 11 years old, and then even most of them decrease through adolescence, so that by the time you get to 20 years old, it's really a small minority of the kids with even chronic tics who have a problem. So what do you do with tic disorders in terms, why do I put this in about medicine? Well, I put it in because the first thing that you do is probably nothing. Okay, you don't have to treat these children with tics. And if you do treat them, what you're going to be looking for more commonly is the comorbidity. Okay, that's what you're going to treat. These are kids who have oppositional defiant disorder, they have anxiety disorders, they have depression, and they have ADHD. And sometimes you're going to treat that. You're not really necessarily going to treat the tic disorder. Now, that said, if you do treat the tic disorder, you're going to start with clonidine, which is kind of off-label, or guanfacine, which is off-label, but seems effective and doesn't have a whole lot of side effects compared to Haldol and Orap, which are old antipsychotics, which do have a lot of side effects, even though they're FDA approved. And lately, the second generation antipsychotics are there. Time? Okay, we're ahead of schedule now. We're good. So now, sleep. I'm guessing. Just raise your hand if this is a slightly frequent problem that you address with parents. Yeah, I mean, it's this is where the action's at. Parents want their kids to go to sleep, for obvious reasons. Okay, so what do you do for these kids? Well, the first thing you do is behavioral intervention. There's no FDA-approved medicine, and even if there was, what we have to say is that you're going to treat it behaviorally first. And there's a whole way of dealing with that, of looking at what's going on at night, but kind of getting it takes time to get the parents to relax and say what's really going on in your house at 9, 10 o'clock at night. And you hear all sorts of stories about who's sleeping where, like musical beds and things like that. So you want to do that behaviorally. On the other hand, with adolescents, it's not simply behavior, but about 50% of them are going to have a comorbid psychiatric disorder. You want to know that. If it's an adolescent, is he or she depressed? Do they have an anxiety disorder? So that said, sometimes it comes time to use a medicine, and these are just many of the medicines that are used, again, all off-label. I put melatonin at the bottom. It's over the counter, but just because something is over the counter, and I always explain this to parents, don't assume that it's just safe, okay? Quick story. So I have a patient who is somebody I've known for many years, and she was an adult. She's feeling kind of lethargic. She goes to the health food store. The guy says, I have just the thing for you. Take this medicine over the counter. She takes the medicine. A couple of months later, she's feeling absolutely great. She goes, and she happens to have a thyroid disorder, and she goes in for a checkup with her endocrinologist, and she says, I'm just feeling like great. And he says, well, how come? He says, well, I went to the health food store, and the guy gave me this medicine. And she says, well, what is it? She says, I don't know, here. She reaches into her bag. He looks at the medicine, and in the medicine is thyroid hormone. Okay? This is over-the-counter medicine. The patient told me, the endocrinologist, she had to peel him off the ceiling. Okay? That's how angry he was. So the point is, just because it's over-the-counter doesn't mean that you know what you're getting. Okay? I also tell parents that just because it's natural doesn't mean it's safe. Okay? Nicotine is very natural. Okay? Alcohol, poison ivy, they're all natural substances. Okay. And that's, so there are always contaminants, found in all this stuff. So now, helping parents decide. I've made this is kind of just a handy-dandy way for you to think of things, okay? It is simplistic. The world is not so categorical. I realize that. But think of it like that. Benefit, low risk, low benefit. If you have a child and you're talking to parents and they're thinking about using a stimulant for ADHD, and the child he doesn't have malignant ADHD, it's kind of ADHD, that's kind of low benefit, low risk. It's not a big issue, I think, to use medicine. In the green zone are things like an SSRI for debilitating OCD, like that's a high benefit. You're going to change the child's life, get them to go back to school, and the risk of the SSRIs is very low. In the lower right, there are the kids who have just malignant, comorbid everything, and they're on some concoction of medicines that only the guy prescribing it knows what's going on, but it works, okay? And those kids, you're clearly off-label, you're off everything, you're out of research, but you're saving the child's life. That just happens. That you all know those cases. You want to avoid the red, okay? Where there's, the child who is having some kind of an adjustment disorder. His parents are getting divorced. He's irritable, blah, blah, blah. Mother's, pulling her hair out. She goes to the doctor. Doctor says, take Abilify. Well, you know what? That's the wrong treatment for that, and that's the box that you want to stay out of. Okay. What do we got? What time we got? 57. Okay, so just a couple of quick points. By the way, just a round of applause for the timekeeper. I mean, you got us through. You got us through this. Okay, so 10 Commandments. So just a few things. Number one, my number one commandment, always start with an appropriate evaluation before, we talked all about medicine today, but before you go to medicine, the child should be evaluated. And that means really sitting down. And I realize that nobody has time for this. I have more time than you do. I know that you're pressed for time, but somebody's got to sit down and do an evaluation. And then before you do medicine, before you write a prescription, is there anything that you can change in the environment? Whether it's CBT, whether it's supportive therapy for the depression, even for the simple child with simple ADHD, can you do behavior therapy? Also, you want to explain to parents the difference between a disorder and a symptom, okay? Because there's definitely, we live in a world of spectrums now, and they should kind of know what's going on. Next, you want to avoid the medicine rut, okay? Using medicine every day just because you did it yesterday. Now, having said that, I find that a lot of times the parent who is reluctant to start the medicine, okay, now it's a year later, and I'm saying, you know what, I think we should give the child a trial off the medicine. And the parent is saying, I don't really want to do that, okay? And I appreciate what they're saying. What they're saying is, I don't want to go back to where we were. Those were very painful times, and I don't want to go back there. And so, kind of in summary, you want to know when to stop the search for medicine. I mean, sometimes you have to use medicine. Sometimes it's on-label, hopefully. Sometimes it's off-label. Sometimes you do things that are a little strange because nothing else is working. But you have to know when to say, you know what, enough, okay? I've done it. It's not a matter of medicine. We have to figure out another way of dealing with this problem. So with that, the big conclusion is that medicine is a help. It is not a belief, okay, like a belief in God. It is a help. It is scientifically proven help, but it's not perfect. It's got side effects. It's got benefits. It's basically one tool in the toolbox. And with that, what time we got? 59. I have time for one question, but then we have to get out of here. Okay. One question, but then we have